We begin tonight talking about your health. Joining us are Dr. Elizabeth Nichols, radiation oncologist at the University of Maryland Greenebaum Comprehensive Cancer Center, and also the Maryland Proton Treatment Center. Dr. Meghan Garstka, surgical oncologist at the Greenebaum Comprehensive Cancer Center and the Kaufman Cancer Center at the University of Maryland Upper Chesapeake Health. Both doctors also on the faculty at the University of Maryland School of Medicine. Thank you so much for joining us.
Yeah, thank you for having us.
You are in pink for Breast Cancer Awareness Month.
We are.
Unfortunately, it affects so many people, but there's some good news in terms of the advances in early detection and treatment.
Absolutely. We do know that breast cancer is one of the most common things we see diagnosed in American women. 1 out of every 8 women may have this diagnosis at some point. So that's about a lifetime risk of about 12.5%. We do consider there to be some patients who are higher risk for breast cancer, so that's about a 20% or higher lifetime risk. So unfortunately something very, very common. And so, like you mentioned, we do have a lot of good treatment options now.
And you both specialize in those treatment options, the surgical side and the radiation side. And are these cases most often detected by mammograms?
Yes, so the most common way breast cancer is detected is by mammogram, but of course we still have a lot of patients in our country, both in our state as well as, again, nationwide, who unfortunately don't undergo their screenings. And in those patients, oftentimes we only find it because they felt something, which means it's oftentimes a lot more advanced.
And for the treatments that you both provide, I'm sure you'd much rather see somebody early.
Oh, yes.
Yes, for sure.
How big a difference does it make?
It's a pretty significant difference in terms of treatment options. So when we look at staging of breast cancers, we look at the size of the lump in the breast, we look at people's lymph nodes, which are your drainage system to tell if cancer has moved in the body. And so we are definitely in an area where less is more in terms of treatment. So the earlier that we find things, the more options we have in terms of surgery, in terms of treatments to help prevent the breast cancer once it's removed, things like radiation therapy. So I think in general, we are always happier to find it earlier.
Tell me about less is more in terms of treatment.
Sure.
I thought a doctor would say more is more.
No. Yeah, good point. Years ago they used to think that every patient had to have a mastectomy, remove the whole breast to make sure that the breast cancer was cured. Then we found that a lot of times we can do what we call breast conservation and remove the lump and do things to kind of help clean up the breast. Things like the radiation therapy, things like sometimes we talk about endocrine therapy to work on a woman's hormone levels and things like that. So there are certainly a lot more treatments than there were years ago. And in terms of things like surgery, even with dealing with mapping out patients' lymph nodes to tell which lymph nodes are the ones that drain the breast, we can actually do a lot more in terms of less surgery, because the more that we do in terms of removing lymph nodes, there's always a risk of side effects like things like lymphedema, which is arm swelling and stuff like that. So in general, we like to see the less is more in terms of surgical options and certainly for those preventative options.
Well, let's come back to the mammogram side and the idea that we really, really want to pick this up early. What are the current screening recommendations?
Yeah, so the current screening recommendations are that women begin undergoing mammograms at the age of 40 and then undergo a yearly mammogram at least until around 70 or so. However, as we age, it also becomes kind of a conversation with your individual doctor based on your other health problems and so forth too. But then the other thing to always remember is that if you have a family member who's had a breast cancer, especially at a younger age, then we actually will recommend earlier screening. Or sometimes if, for example, you have a, one of the genes that run in your family that can lead to an increased risk of breast cancer, we'd also recommend earlier screening for those patients as well.
Any fights with insurance companies about covering screening if it's a little earlier than recommended?
Unfortunately, yes. I think that's kind of the way that we live in nowadays. But typically, if someone meets the criteria, and there are actually some national cancer guidelines on screening and things like this, usually your team, your doctors can actually fight for that and are able to get that for you.
I remember a conversation about trying to accelerate the amount of time between somebody unfortunately getting a worrisome report on a mammogram, just a question, we need to take a closer look, and getting to the bottom of the situation because it creates such worry. What's best practice there?
Well, I think most of the institutions that perform mammograms typically try to accelerate the process of getting patients through to make sure that they get what we call diagnostic studies, which is what if a woman gets a callback. And so we always stress to patients, keep in mind, not every callback is going to be something bad. You know, we definitely think that there's value in those screening mammograms, and we are really looking for things that can be caught early, so I think you do see a lot of callbacks. That being said, you know, we use complementary tests too. There are things like breast MRIs. If women do have dense breasts, like a lot of times we may pull out additional testing to try to figure out what's going on imaging too. In terms of what we advise women, if they have questions about their family history and what age to start, as a general rule, we look at that age of 40 now. It depends on the guidelines that you look at, and it can be a bit controversial in that respect, but most patients, most societies agree that 40 is the right age to start. But we always counsel patients too. We have a lot of great high-risk clinics throughout the system and honestly throughout the state. And so if there's ever any question about like if a patient should start with a screening MRI at an earlier age or a mammogram if they have dense breast, that sort of thing, we encourage them to just schedule a consultation to talk about that breast cancer risk.
Remind our viewers, if you have a question for the doctors about breast cancer, send us an email, livequestions@mpt.org. The idea of dense breast tissue and a mammogram, is that itself a risk factor, or is it just something that makes it harder to read and perform a mammogram?
Yeah, so it's the latter. So it makes it harder to perform and read the mammogram. Now, there have been some advances in mammogram technology, including 3D mammograms, which are really kind of the standard now, at least I'd say nationally and definitely widely available in our area, that help the radiologists take a lot more pictures and kind of help determine that a little bit better. But again, most women have probably seen on their own mammogram report that it will actually grade your breast density and say that this can sometimes limit the test, which of course causes a lot of anxiety for patients as well. But that's where, as Dr. Garstka was saying, that we can sometimes use some additional tests to monitor those patients.
And Dr. Nichols, I think you brought up the genetic side of this, the different genes that are involved. Who should find out about that? I mean, if you know there's family history, then you get into the genetics, or everybody should?
Yeah, so that's a great question, and it's a little bit of both. So again, there are some clear guidelines on which patients are candidates for getting genetic testing, but again, women who are under the age of 50 who get breast cancer are all eligible for genetic testing, women with triple negative breast cancers as well. Again, certainly if you have a family history where someone else in your family has a genetic mutation, then you can also get testing as well. But those guidelines are actually rapidly changing and change every year, honestly. So it's actually something we have to keep up to date on very significantly.
Exactly.
What does triple negative mean?
Triple negative, so it's a type of breast cancer. We look at some different receptors, or I like to call like flags that the tumor cells can put up to the body. So most breast cancers respond to your female hormones, to estrogen and progesterone. There are some types that do not, and those tend to be a little bit harder to treat in the sense that we can't work on your female hormones to prevent them. So typically those tend to be tumors that come up a little bit more quickly, but we have good treatments for those too. And when we talk about quickly in the world of breast cancer, we're talking more on a scale of months to years, not days to weeks. So this is still something where we're talking about, you know, screening can certainly pick up on those changes, but this is, you know, definitely something we look at, just how do you prevent it in the future too, looking at those little receptor flags. So that's what triple negative is.
I think everybody watching is probably, unfortunately, familiar in some way with the staging system for cancers. But in breast cancer, sometimes you hear the phrase stage 0. Mm-hmm. Is that a thing? What is?
Yes. So breast cancer is actually the only cancer that has a stage 0. And so that's actually when we find cancer cells just within the duct of the breast, which we call ductal carcinoma in situ, or we abbreviate it DCIS. And so it is actually a non-invasive form of breast cancer. It doesn't have the ability to spread, but is managed very similarly to an invasive breast cancer.
Viewer question, this is from Megan. So you can answer. Can you talk about contrast-enhanced mammography?
Sure. So that is a newer technique in terms of where we're going with imaging, like you mentioned. So what a contrast-enhanced mammogram does is it basically is looking at the energy use of the tissues of the breast, just like an MRI would do, but using a normal mammogram. So it is a newer technique. We do like to use that technique if we're trying to find out if there is energy use by that particular tumor, if you want to think of it that way, or by that particular finding in the breast to make sure it's not a tumor or something abnormal. So contrast-enhanced mammograms are certainly a great option. It's something that not everyone needs to do, but it's certainly helpful in certain circumstances. So it's an option that we have at a lot of different facilities, and I do think it is a good one. But again, that would probably be something to talk about with your provider, just to find out if that's the right one for you.
I wanted to ask about those provider to patient conversations, because you both do really delicate, precise work in surgery and directing radiation beams, but in talking to your patients, that's also really important, and it's also really precise. What you say, what you hear. Tell us about those very difficult, I mean, it's a conversation you have a lot of times. The patient has it once.
Yep. Yeah, well, surgery often comes first. I'll let you comment first, then I can comment from a radiation perspective too.
Well, I think in the world of oncologic surgery, with what means like any type of cancer surgery, we certainly have these difficult discussions. And I think with breast cancer surgery, more and more we're talking about individualized options. So I think our role is to make sure that patients know all their choices and to make sure that patients are truly informed. And I definitely like to make sure that my patients are aware of all those choices that they have, whether it's keeping the breast, doing breast conservation, doing a surgery with plastic surgery to help rebuild the breast if they're going to have a mastectomy. So I think a lot of what we do is trying to be tailored for our patients to make sure that we know and take into account all of their circumstances of not just this diagnosis, but for the future. So there is a lot that we're doing in that respect.
Yeah, and then from a radiation perspective, again, one of the big things about radiation is that it can be a daily treatment Monday through Friday for several weeks. Well, a lot of patients don't have resources to do that, or they don't have a family member who can drive them each day. And so a big part of those individualized conversations for me are really understanding patients' kind of social issues, transportation issues, do they need someone to take care of their kids, all those types of things. And that really helps us inform us kind of which regimen we may choose or which regimen might be best for that patient's cancer based on their stage.
Very good. Drs. Nichols and Garstka of the University of Maryland Medical System. Appreciate your time. Thank you so much.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.